Okay. All right. So this was I got to do this weekend. I got to hang out with my brother for I don't get to hang out very often. I went to South Carolina, watched my brother get married, so remarried for the second time. So that was awesome. He picked a better one this time. So we were all very happy to be there, and so excited to have a new sister-in-law that will probably actually come hang out with us occasionally. So, but everything went smooth. we uh, so we were supposed to fly out Thursday, and then we missed our connection, so we ended up having to go Friday. Fortunately, well, we didn't miss our connection. We were here in Dayton, and the flight was leaving so late that knew we weren't going to make our connection, and they couldn't get us out. But everything went other than that, everything was smooth. We got there in time for the wedding, so that was the important part. So, but that is my brother. He's 14 months younger than I am. His name's Kyle. So Kyle. So we got the Kurt and Kyle, kind of theme going there. So, but all right, and his wife's name is Krista. So now we got a Trista, Krista, Trisha. I'm just every time I say their names, I say the wrong one. It seems like so. Did not say his ex-wife's name in front of her, which was good. I was very good about that. I did not blow that one. So, all right. So let's talk about autonomic nervous system. What does it do? Critical for survival. Regulates homeostasis. Okay, it's the thing that's happening autonomically, automatically, however you want to think about it. Innervates secretory glands, blood vessels, heart. Plays a big role from a standpoint of what we're concerned about is regulating blood pressure and blood flow, so especially during exercise, physical activity, and at rest. Innervates bronchi, the lung, digestive and metabolic functions, kidney, bladder, large intestine, rectum, also sexual responses. And when we get to spinal cord injury, we'll talk about some of those, how it affects bowel and bladder and sexual function as well. That's why you care about it, okay? How it will affect exercise. So the autonomic nervous system, just like our somatic nervous system, so our somatic nervous system to our body, like the sensory and the motor systems that we've talked about, the autonomic nervous system has kind of a sensory and motor part to it as well. So it's got the part that brings in information, so it knows how to respond, with its efferent part. So it's an afferent part that acquires information about what's going on in your systems and in your body, so then it can respond to that. Make sense? Okay, and so the afferent is called the general visceral. The GVA just stands for general visceral afferent. You don't have to memorize that, but you may, in reading about the nervous system, you might see something that says general visceral afferent. That's the afferent part of the autonomic system. It's bringing in general visceral information, and it's bringing it in. So it's afferent. Okay, and that information is coming into the spinal cord from T1 to L2, and also S2 to S4. There's afferent information that comes in to help guide the autonomic nervous system in its efferent responses, okay, and regulation. And then also cranial nerves 7, 9, and 10 also have sensory components or afferent components to them as well, okay. And we don't classify the afferent part of the autonomic nervous system as either sympathetic or parasympathetic, even though it comes in regions like the thoracolumbar regions, T1 to L2, sacral regions, and cranial regions. We just say this is the afferent component of the autonomic nervous system, and they come in. That afferent comes in similar regions that the efferents go out. Okay. The efferent, which is the general visceral efferent system, okay, the general visceral efferents are the sympathetic and parasympathetic portions, can divided into sympathetic and parasympathetic portions. Those are the things that are doing the activity, eliciting the responses in your tissue and organs. So the sympathetic division of that, which is exiting out of T1 to L2, and the parasympathetic part, which is in the cranial nerves, 3, 7, 9, and 10, and then the sacral component between S2 and S4 is where those efferents come out. We're going to mention the afferents first. How do we get information in to provide the detailed information that your efferent, your parasympathetic and sympathetic are going to need to control and regulate. So we have sensory receptors. Just like we have for our body, we have sensors in our viscera that tell us about the state of our organs, okay, and what's going on as far as temperature, um, stretch within, our gut, our intestines or our heart or our vessels and so forth. So we have a lot of mechanoreceptors that contribute to the afferent part of the autonomic nervous system. We have them in the atrial, ventricles, carotid sinus, the bladder, obviously, intestines. Then we have chemoreceptors that also help regulate responses. So the carotid and aortic bodies that respond to oxygen concentrations and levels. In the medulla, we have receptors that are really sensitive to hydrogen and CO2 concentrations that help regulate respiration. The hypothalamus also has areas within it that are sensitive to glucose and electrolyte concentrations. Okay. Hypothalamus is a little region within it that is actually where there's no blood-brain barrier, so it can sample your blood stream and look for those concentration levels of glucose and electrolytes and so forth. We have nociceptors, so within our organs can have pain, and that pain can drive sympathetic responses as well. So there's actually, those would be free nerve endings that would provide those nociception. And same with thermoreceptors. Those are also free nerve endings that tell us about temperature in our body and in our internal organs, okay, so we can make proper adjustments. And then how does this visceral information then get from those receptors to the CNS? Via the cranial nerves is one way. That's going to be through 7, 9, and 10. So taste and sensation of your throat for swallowing, for helping coordinate swallowing. So that's coming in through 7, 9, and 10. It's a combination of your taste and that sensory you need to coordinate kind of automatic swallowing responses, okay, the back of your throat and so forth. And then the visceral information is coming in through 9 and 10. And 10 is the big one there, the vagus nerve, okay, has some afferent information coming in that really tells you a lot about what's going on with the majority of your viscera. The spinal cord is also receiving afferent information in those T1 to L2 regions, and that's carrying, again, information from the viscera and trunk that's going into the spinal cord, and then that can be transmitted up to higher centers, including the hypothalamus, limbic system, and so forth. Or you have reflexes. You actually have autonomic reflexes in your spinal cord that allow immediate on-demand kind of shifts in blood supply, heart rate, especially for posture responses and things. So you can have actually spinal cord reflexes that can elicit. And that becomes an issue when we have a spinal cord injury and we lose control from descending higher centers. Our autonomic spinal cord reflexes can go a little haywire. Just like we can have hyperactive motor systems when we have damage to the spinal cord, we can have hyperactive autonomic reflexes, especially sympathetic type reflexes in the spinal cord. And then also there's afferent information coming in the spinal cord at the S2 to S4 regions, okay? And what's interesting about these is that this is one of the only places where you have afferent information that comes in the anterior roots of your spinal cord. So most of the time your afferent information comes in the posterior root. Your somatosensation, which we talked about, all comes in the posterior root. And then also at the T1 to L2, that comes in the posterior root of your spinal cord. But in S2 to S4, it comes in the anterior root, which is kind of unique. Then you have central regulation of your autonomic nervous system, which is driving your responses. That is driving responses as also by taking in the information from the afferents, making sense of it, and then helping tell your system how to adapt or accommodate or adjust to whatever the current state is of your system, okay? These are the different levels of control we have or regulation of our autonomic nervous system. So we have some control over autonomic, even though it's mostly automatic, we do have a little bit of control over autonomic nervous system. And actually probably more than we can train yourself to have a lot more control. Anybody ever watch David Blaine? That guy is just an absolute freak. I mean, doesn't he have I think he has the world record now for holding his breath, right? I don't know what it is. Do you guys remember what it was? I mean, it was something silly. I mean, like 13 minutes or something like that. I mean, And that requires reducing your metabolic activity, your respiratory rate, down-regulating all your systems through conscious control. So if you work on it, you can have a lot more control of your autonomic nervous system than you think you do. And that can be used for helping people with pain, and those kind of things, and dealing with that. But also for micturition, for urination, you can decide most of the time when you want to go or when you don't want to go. Kids can't do that when they're young because they haven't fully myelinated the pathways that are controlling from your conscious ability to tell your bladder or your sphincter and your external sphincter to keep it hold it for now. And kids develop at different rates as far as how quickly they myelinate that pathway to be able to do that. Then same with defecation and breathing. We can hold our breath when we go underwater and those kind of things if we want to. So those are conscious control of autonomic nervous system kind of functions. Limbic system. There is emotional influence on our autonomic nervous system. So the limbic system can drive, when you get nervous, when you're up for a nice little talk that we make you guys do all the time. That can be just your sympathetic nervous system kicks in a little bit, and we have a little bit of our diaphragm and so forth, and even our muscles, they oscillate. They kind of about a 14 cycle per second oscillation, like there's a little bit of a baseline impulse you send to most of your muscles. When your sympathetic tone goes up, that increases and that strong. Then that's and that butterfly is your diaphragm increasing the strength of that like little cycling response that you feel. Anyway, that's limbic system drive over that, which you can also learn to regulate and tone down with practice, with meditation, breathing techniques. You can reduce some of those things, and you can help the limbic system be a little more cooperative for you. The thalamus is important. It's a relay center for afferent information that's going to end up going to the limbic system and cortex. So if you sense your bladder being full, that information has to go through the thalamus before it gets to your cerebral cortex. Or if it's going to go into the limbic system to influence limbic system drive over the autonomic nervous system. And then the hypothalamus. This is the key structure for regulating, one of the key structures, but it does probably the greatest role in control over the autonomic nervous system. It's kind of the master regulator. It receives its information from the reticulo-hypothalamic tracts. Reticular formation is in the brainstem, so these pathways, these afferent pathways that come in often go up into the brainstem, and then from the brainstem they go up into the hypothalamus via this reticulo-hypothalamic tract. So reticular formation, that's that kind of area in the middle of the tegmentum of the brainstem we're going to get into later via the reticulo-hypothalamic tracts. They regulate cardiorespiratory. They play a role anyway in regulating cardiorespiratory, metabolic, water reabsorption, digestion, reproduction. So the hypothalamus plays a role in all of that. It also helps. It does this also by helping, exerting some control through the pituitary gland through release of hormones that are going to regulate some of these things, and also a descending pathway. There's actually a descending pathway from the hypothalamus that goes down to your sympathetic T1 to L2 kind of outflow, and also down to the S2 to S4 nerve roots there, and also can influence some of the brainstem cranial nerves as well, and that's through what's called the dorsal longitudinal fasciculus, the DLF. And when we get into cross sections through the brainstem, we're going to see this little DLF, the dorsal longitudinal fasciculus. It's running down it's a little bit of the dorsal part of the brainstem. It's a small tract, but it's called the dorsal longitudinal fasciculus to brainstem centers and spinal cord to help control parasympathetic and sympathetic outflow. The midbrain plays a role in control of the autonomic nervous system. In the periaqueductal gray, remember there's the cerebral aqueduct in the midbrain. There's a little bit of gray matter around that. We talked about that periaqueductal gray plays a role in descending pathways for pain control, but it also has a little area in it that's important it's the micturition center for helping control over your bladder. Okay, so that's one of the control centers for the bladder is in this periaqueductal gray. There's also in that periaqueductal gray is another little nucleus called the Ettinger-Westphal nucleus, which is the parasympathetic control through cranial nerve number 3. Okay, so we'll talk about that when we get to that. When we get to cranial nerve number 3, we'll talk about that. So it's the parasympathetic fibers, so a few parasympathetic fibers going out through cranial nerve number 3 to the eye. The pons also has some areas that are important for autonomic nervous system control, primarily for respiration. This is where your pneumotaxic center is. There's also another micturition center. So the periaqueductal gray micturition center and the micturition center in the pons have to work together to give appropriate bladder control. Okay. Then in the medulla, there's some really important control there that's going on. So we have some of your primary regulation of basic heart rate and responses, respiration, the respiration centers in the medulla, swallowing, coughing, chewing, vomiting. Those are all medullary functions. That coordination between some of the cranial nerves there, especially 9 and 10 there, are going to be able to help coordinate a lot of those functions. Okay. In the medulla, we have this thing called the solitary nucleus, which we get to the cross section. You're going to see the solitary nucleus come up. It is a afferent structure. It is a nucleus that receives afferent information primarily from cranial nerves 9 and 10. This is where most of your visceral information coming in through those two nerves are going to go in and communicate with the solitary nucleus first, is that afferent structure there. Okay? And then that relays information via the reticulohypothalamic tract up to the hypothalamus and to other brainstem centers as needed. Spinal cord, we have those autonomic reflexes I mentioned, where it takes in afferent information and can reflexively go back and do sympathetic reflex type responses and changes in vascular tone and in heart rate and things like that. And it's also the pathway for afferent and efferent control of the autonomic nervous system. Anything coming in down in the spinal cord can go up or down through the spinal cord for regulation of that. So this is just from your book that shows kind of an overview. You've got a sensory component on the left there that is bringing in through the visceral afferents. These visceral afferents go to all levels of your nervous system: the spinal cord, reticular formation in the brainstem, the hypothalamus, the limbic system. And some of it actually gets up into the cerebral cortex as well. They don't show that here, but they're just showing you mainly what's mainly under unconscious control here. Okay, they are processed. These all communicate with each other through that reticulohypothalamic tract and also the dorsal longitudinal fasciculus. This is how these guys communicate and send information between these centers for coordination of the response. And then they're going to coordinate the responses. And the efferent pathways are your sympathetic, parasympathetic, and then hormonal through the pituitary gland and also the adrenal medulla in the kidney. Okay, that's how you're going to drive whatever responses or necessary adjustments made by that processing that took place through those central structures. So now we're going to go into the efferent control and the actual sympathetic and parasympathetic systems. So what is the difference between the somatic motor and the autonomic efferent? So there's actually the somatic motor is what we're going to talk about starting Friday. Okay, that's your efferent system to drive skeletal muscle, voluntary action and those kind of things. That's called the GSE, general somatic efferents. The autonomic efferents, the sympathetic and parasympathetic, they're called the general visceral efferents. So just, again, introducing you to that terminology in case you see it there. So you'll see on the left here, the somatic motor, this is just central nervous system. Spinal cord, everything, brainstem, all lumped together. In the somatic motor, you have your cell body here in the CNS, and then one long axon that goes out to your skeletal muscle for motor activity. And these cell bodies just happen to be lying in your spinal cord in that anterior root, or anterior horn in the spinal cord, okay? However, your sympathetic and parasympathetic efferents, okay, there's typically 2 neurons in this pathway before they get to their effector site, okay? And with the sympathetic nervous system, you typically have what's called a preganglionic neuron that's a little shorter, okay? So here's the cell body somewhere in the central nervous system, a short preganglionic fiber. Then we have this ganglion, which is outside the central nervous system, where you have then the next neuron and a long postganglionic fiber that's going to go to innervate some type of smooth muscle, cardiac muscle, gland, tissue. Okay. Parasympathetic, most commonly, are exceptions to some of these rules, starts in the central nervous system with a preganglionic fiber that is fairly long. And then the ganglion, the autonomic parasympathetic ganglion, is usually farther away from the central nervous system, closer to the effector organ, okay? And then you have a short postganglionic fiber, okay? So you have a short postganglionic fiber here that then goes on to those smooth muscle, cardiac muscles, and glands, and they pose each other most of the time. They're posing, actions to up-regulate or down-regulate function. So that's the difference between those efferent systems. So we have some neurotransmitters that are used in our autonomic system, okay? We have cholinergic neurotransmitters, acetylcholine is the one mainly there, and then we have adrenergic neurotransmitters. And those would be norepinephrine and then epinephrine, okay? And we'll talk about those differences and where those are coming from here in a second. The cholinergic neurons, here's a good, remember, all of the preganglionic neurons in the entire autonomic nervous system use acetylcholine at that, between the pre and postganglionic fibers, okay, as acetylcholine. And it's also secreted, cholinergic neurons, or acetylcholine is used at the postganglionic neurons of the parasympathetic nervous system. It's also, here's an exception to the rule, sympathetic postganglionic neurons that innervate sweat glands, and a few sympathetic postganglionic neurons that innervate skeletal muscle vessels that are in skeletal muscle. Some of those also release some acetylcholine. That's kind of an exception to the rule for the sympathetic nervous system, which typically releases norepinephrine, okay? So this is the cholinergic neurons. That acetylcholine then binds to receptors, okay, to cause its effect on the next neuron. There are two groups of cholinergic receptors. There's the nicotinic receptors, which generate fast excitatory postsynaptic potentials, okay? So those are going to just open sodium channels typically and cause some depolarization of that next neuron, and it's going to be in that fast excitatory postsynaptic potential way. Then there's muscarinic receptors that are G protein mediated responses, okay? Those can be either excitatory or inhibitory, depending on the organ or system it's falling on, and so forth. And these are G protein mediated that are a little more longer lasting, a little more complex in nature as far as how they're going to have actions with them. So those are the two types of receptors that acetylcholine can fall on. Then the other big class is the adrenergic neurons and receptors. Okay, so these are the ones that are norepinephrine and epinephrine, okay, or adrenergic neurons, and then the receptors. Most sympathetic postganglionic neurons are going to release norepinephrine. So that postganglionic neuron that's going to communicate with that effector site or organ or cardiac tissue, smooth muscle, there's going to be released norepinephrine at that site, okay? We also have the adrenal medulla. So the sympathetic nervous system can stimulate the adrenal medulla, which is sitting on top of your kidney, to release epinephrine, which is a little different, and some norepinephrine. I think it's like an 80-20 kind of mix that it releases into your bloodstream. And it takes a few seconds, minutes for that to happen to get that circulating around in your bloodstream to start having an active effect, okay? So there's some delayed response there with the adrenal medulla when it starts secreting some of its epinephrine and norepinephrine. There are two groups of adrenergic receptors. There's alphas and betas, okay? And with both alphas. There's two types of alphas, an alpha 1 and alpha 2, and two types of betas, a beta 1 and beta 2. And depending on the affinity for these to bind, norepinephrine and epinephrine and their sensitivity to those will determine the action that takes place at the organ that these things, or where these receptors are located. So different systems, different organs in your body will have different concentrations of those receptors, and that will guide, influence their responses. So actually your book finally got a good table or chart in there, and I just added this, and I'll re-upload this presentation. I was just making changes actually this morning to this presentation. I like pictures. This is a great picture. This is a great picture that summarizes most of what I just went through. Okay, so parasympathetic and sympathetic. Let's go through this and just make sure you fully appreciate how nice this little table is here. So it's here's your CNS here, right? This is central nervous system, and it's broken up into, actually, this would be up here, your parasympathetic, okay? And then this would be sympathetic, and then here's parasympathetic for sacral location, okay? So this is sympathetic. This is like cranial nerve kind of function up here, and then this is more the sacral part of the parasympathetic system, okay? And so you see how your parasympathetics have this longer preganglionic neurons, and your sympathetics have a little shorter preganglionic neuron. You'll see that every preganglionic connection uses acetylcholine, okay? And then you see the organ systems that it has influence over and what it does, and the type of receptor. Well, it also shows you what the neurotransmitter is for that postganglionic neuron and the type of receptor that it falls on. So this would be a muscarinic receptor, cholinergic muscarinic receptor for that. And this shows you, alphas here. This is norepinephrine, 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 and then it's using alpha receptors primarily. Okay, actually I should uncircle that one. And this is the heart uses beta 1 receptors, and in the lungs are beta 2 receptors binding norepinephrine. Here is the supply of the sympathetic nervous system to your adrenal medulla, which you see really doesn't have a pre and post ganglionic neuron there. It just goes directly to the adrenal medulla and tells the adrenal medulla to secrete epinephrine primarily. It also secretes a little bit of norepinephrine, but epinephrine tends to affect alphas and betas fairly equally, where norepinephrine is kind of specific to where it's released here to either alphas or betas through the heart and lungs, where they have the direct connection there. But the circulating epinephrine and norepinephrine kind of works on all of these somewhat equally. It just kind of is diffused through your body and just ramps up general sympathetic tone, sympathetic activity, especially when you're doing things that are lasting several minutes, like during exercise for long periods of time. That's plenty of time for your adrenal medulla to kick in and just start dumping more epinephrine and norepinephrine just to kind of ramp up heart rate, respiratory systems, metabolic systems, and so forth, is what the adrenal medulla is doing, okay? And then we have down here, this is parasympathetic control over bladder, sexual function, rectum. They just show bladder here, but it's also your, rectum and so forth as well, and that's via muscarinic binding of acetylcholine and muscarinic receptors. All of these are the fast ESP. These are the nicotinic. The preganglionic neurons are nicotinic receptors for acetylcholine, that fast EPSPs, excitatory postsynaptic potentials. All the post are all muscarinic. That acetylcholine falls on that postganglionic, or on the not post, but on the postganglionic nerve is secreting to the organ tissue or skeletal muscles, smooth muscle glands. So that one picture does much for me. if I have a picture in my head, that's how I like to. This is a similar picture that just shows you, like it shows you general rule. This is kind of like parasympathetic. It's got acetylcholine and nicotinic receptors, acetylcholine and muscarinic receptors in general on cardiac smooth muscle glands. Then your sympathetic nervous system, this is just showing you the rule is norepinephrine on an alpha or beta receptor. But then here's your exception to the rule. There is an exception for sweat glands. So for sweat glands, you secrete acetylcholine on muscarinic receptors, but it's still sympathetic, part of your sympathetic nervous system. There is also an exception to the rule for some renal vasculature where you actually secrete some dopamine, but don't worry about that on D1 and D2 receptors. But just know that there is some, for certain select things, there are some exceptions to the rule. So. All right, so now we're going to go through sympathetic nervous system. So sympathetic efferent neurons, cell bodies, preganglionic neurons, they're located in the lateral horn of the spinal cord between T1 and L2, okay? This little lateral horn. Remember we've talked about a posterior horn, a dorsal horn, where sensory information comes in, an anterior horn where somatic motor that goes to your muscles is coming out. There's a little lateral horn. We'll show you here in a picture where there's a little lateral horn where the cell bodies for the sympathetic neurons are that are going to also go out that ventral root, okay, with your motor system. They exit the ventral roots through the white ramus, and we'll show you what that is, and then a synapse in the paravertebral ganglia. Remember, the sympathetic nervous system have those short preganglionic fibers. They're going to go just outside the spinal cord and make a synapse most of the time, okay? Sometimes they'll actually go into this sympathetic trunk, it's called, where there's actually a little area right along your vertebral bodies where you have the sympathetic chain ganglia. These ganglia are a chain of them, and they're connected, and that whole thing together is a sympathetic trunk. And some of your preganglionic sympathetic fibers, instead of making an immediate connection at that sympathetic ganglia right outside, they'll go up or down a few levels or even up really high like up into your neck before they make their connection with a ganglia in different regions, okay? So some go straight through to synapse and ganglia closer to the target tissue. There are some exceptions. Remember I said there's some exceptions to this. So there's the celiac and mesenteric ganglia, which in the sympathetic nervous system are actually closer to the target tissue. So they have they have a longer preganglionic fiber potentially in those particular situations. As a general rule, though, most of the postganglionic nerves pass through the gray ramus and then enter the ventral or dorsal ramus of the peripheral nerve. I'll draw it out. Just stay with me there for a second here. So here we go. I know this is a cross section through a thoracic area segment for a couple of reasons. The biggest one is it has this little guy right here. It has a lateral horn. If you see a little lateral horn on a cross section like that, you know you're somewhere between that T1, L1, L2 region, because that's where the sympathetic neurons exit. So the only place you have those cell bodies in that little lateral horn is in those regions, and that's the origin of the preganglionic fibers for your sympathetic nervous system. And they're going to go out that ventral root to start with, right along with your motor neurons right here. The motor neurons also go out that ventral root of your spinal cord, okay? And then once they go out here, there's a gray ramus and a white ramus, we call it. So it comes out through the ventral root, goes into the gray ramus, which is this little region right here, is the gray ramus, to make its connection with, most of the time, near that where it came out, with its postganglionic sympathetic neuron in this sympathetic ganglia. This little bump right there. Kind of like the almost the equivalent of a dorsal root ganglia, but this is efferent. This is not afferent. This is a motor, visceral motor. Makes that connection, and then it will then go out the white ramus, which is this little region right there. That little region right there is the white ramus. It'll go out the white ramus, and then if it's going to go to the front of your body or to muscles in your limbs, or not muscles, I should say, vasculature in your limbs on the front of your body, it's going to go out this particular region right here. It's called the ventral ramus of your spinal nerve. This little region right there, that's your spinal nerve. And it very quickly divides into a dorsal ramus. This is the dorsal ramus and a ventral ramus. And so the ventral ramus goes to the back part of your body, okay? Mainly your trunk, the back part of your trunk. Your bottom and your back side of your trunk here. The dorsal ramus, that's where motor, sensory, autonomic function goes out to the back, goes in and out of the back part of your body, okay? Through that dorsal ramus, okay? And I'll show you this in an actual more, in a netter picture drawing. It's kind of sitting in your actual tissue and spinal cord. So now occasionally this will come in, gray ramus, but not make an initial connection right there at that level. So it may ascend or it may descend multiple levels before it makes its connection with either one of the sympathetic chain ganglia or like a cervical ganglia up in your, that's going up your head and neck for controlling your sympathetic, regulation of your face, head, and neck, okay? And then there are the exceptions where sometimes it passes right through, and I'm not sure why they show it coming out this way. It would typically be going through this ramus right here, and then it would make a connection in a ganglia, especially like your celiac ganglia for your gut, closer to the gut here, and never make a connection in any of the sympathetic ganglia. It would make that connection closer to the actual gut, is where you'd see that most commonly. So this is showing you some of that. So you can see this is your sympathetic nervous system coming between T1 and L2 right here. Here they are. Here's your sympathetic chain ganglia. And the connections between those are the kind of the sympathetic trunk. And so your sympathetic nervous system in some cases will go right, bypass that and go right out to a ganglia that's closer to the tissue for the celiac and splenic nerves and so forth. But in general, for regulating most of your heart rate, blood pressure and all that, it's going to make some connections in the sympathetic ganglia. So you have those short pre-ganglionic neurons and then a longer post-ganglionic neuron. Here I said some will ascend up to these. You have a superior cervical, a middle cervical, and a stellate ganglion. These are all for going up to your head and face for innervation of facial vessels, for the eye, for your salivary glands, lacrimal glands. For sympathetic control of those, they actually have to go up there because there's nothing coming out of your cranial nerves for sympathetic control of your head and face, right? They're coming out from down the thoracic area, so they have to go back up to your head. And they do make some connections in these cervical ganglia, this superior, middle, and stellate ganglia that are up in here. Okay. So here's what it actually looks like sitting in a cross section through a thoracic vertebrae here. Okay, so here's a horizontal section through a thoracic vertebrae. Here's the spinal cord sitting right here, and here's those little lateral horns right there and right there. Your cell bodies will be sitting right here. They're going to come out through the ventral root. Here's the ventral root right here. It's going to come out the ventral root. It's going to go past this first one. It's going to go into here, this is the gray ramus right here. It's going to go into here, and then there's a cell body here. So this is your preganglionic neuron that's going to communicate with your postganglionic neuron. That postganglionic neuron is going to come back out. This is actually the white ramus. So it's longer than it looks in that previous picture I showed you. And that's the white ramus. The one that's a little more medial is the white ramus. And then it's going to come back into here, and then it's going to decide if I'm going to blood vessels and tissue in the back of my body, I'm going to go out the dorsal ramus here. It's going to go to the back of the body. But if I'm going to go to the front of the body or the limbs, I'm going to go out through the ventral ramus right here. So really, this is your spinal nerve. This is still called a spinal nerve, this ventral ramus and dorsal ramus, but it breaks into two different divisions. They're still spinal nerves, but it's a dorsal ramus of the spinal nerve or the ventral ramus of the spinal nerve. Okay, just some's going to the back of the body, some's going to the front of the body. Okay, and those dorsal ramuses and ventral ramuses of the spinal nerve have motor, autonomic, and sensory information in them. Okay, all combined. So I'm just showing you the pathway that the sympathetic efferents get out of there. And I can draw it one more time. So cell body, preganglionic, sympathetic neuron in the thoracic spine. Lateral horn comes out. That ventral root, still ventral root. Now we're spinal nerve right here. Once they join together, that dorsal and ventral root. Going to go a little bit past I'm going to go past the white ramus so I can go in the gray ramus. Go down the gray ramus, then connect with my postganglionic neuron that's lying in the sympathetic chain ganglia outside this, just right along the vertebral bodies. Then it's going to send its axon through the white ramus, and then it's going to come back in here and then either go out the ventral ramus of the spinal nerve or the dorsal ramus of the spinal nerve to innervate either organs or blood vessels in tissues. And so, got it? Functions of the sympathetic nervous system is primary role, these are important to kind of remember, is maintaining optimum blood supply to organs is one of its biggest roles that it plays, just maintaining optimum blood supply to organs. In general, your sympathetic nervous system maintains some background vasoconstriction of your blood vessels. So it maintains a little bit of background vasoconstriction, okay? Stimulation of certain sympathetic efferents causes additional vasoconstriction. Like when you go to stand up, your sympathetic nervous system kicks in and generates even more vasoconstriction so you don't pass out. So it even increases the vascular tone of your blood vessels and veins so blood doesn't pool in your legs and you don't pass out. Maintains an optimum blood supply to the brain and head. So your body can tell when you're making and standing up through connections with the brainstem centers that knows the position of your body, that you went from a supine to a sitting position, or as you transition, the acceleration of your vestibular system will send signals to your brainstem to tell your sympathetic nerves to go, we're getting up. We can tell we're moving into an upright position. Turn up sympathetic tone to make sure we don't pass out, okay? However, stimulation of different sympathetic efferents can actually cause vasodilation in skeletal muscle during exercise. So when you're going to be exercising, doing prolonged activity, stimulation of certain sympathetic efferents that are within the blood vessels that are in your muscles, that will cause vasodilation. So the background tone is mainly a lot of it's in your skin, and so forth, and some in your muscles too, but a lot of it's in your skin and peripheral blood supply, peripheral vessels. But the skeletal muscle, once you start exercising, it actually causes sympathetic discharge to those will cause vasodilation of the actual muscles, because you need it. That's your muscles are being active, so they need more blood, and we'll show you. We'll talk about how that's done. So, also regulation of body temperature. Sympathetic nervous system plays a real important role in regulation of body temperature. If you want to just increase your body temperature in general um, and metabolism, your adrenal medulla will start to generate and just release more epinephrine, okay, and some norepinephrine that circulates and infects a lot of all your body systems to raise metabolic rate, okay, and that will help you to generate a little more heat, but it also causes your skin capillaries to constrict, so blood is going more towards your center of your body. If you're trying to raise, you don't want to, if you get blood to the surface of your skin, you dissipate more heat. If you constrict the periphery of your blood in your skin, you're going to retain more heat. So if you want to, that's how you can, by turning on or off the sympathetic nervous system here, up or down, that's how you can generally regulate your core temperature and some body temperature via those two mechanisms, by control of the skin, blood flow, also sweat glands, okay, whether you're increasing sweat responses and getting more evaporative cooling or reducing those, and then also just general metabolism, overall body metabolism, and that's done through that epinephrine system released by the adrenal medulla. Now let's talk specifically about this regulation of blood flow to the skeletal muscle. So skeletal muscle arterioles contain both alpha and beta-2 adrenergic receptors and some muscarinic cholinergic receptors, which is one of the exceptions to the sympathetic rule, okay? When you do norepinephrine that binds to alpha receptors, that causes vasoconstriction. And that's most important to background and position changes. And you have a greater number of alpha receptors in the skin, capillaries, and vessels than you do in the muscle. You still have some in the muscle that will cause some vasoconstriction in the muscle during postural position changes, but a greater proportion of those alpha receptors are in the vessels of your skin and periphery, and those will vasoconstrict with position changes to maintain blood pressure during position changes. However, when you start exercising, and your body, after a minute or two of warm-up, it realizes, hey, we're going to have to maintain this. We got to keep these muscles now are going to be working for a long enough period of time. We got to increase blood supply to the muscle. Well, your adrenal medulla starts secreting epinephrine. And that epinephrine starts circulating. And that epinephrine will start binding to these beta-2 receptors in your skeletal muscle, which causes vasodilation, specifically in skeletal muscle. But that takes a few minutes to occur. And then you start getting the blood supply increasing to your skeletal muscles because you're exercising. You will also start to secrete acetylcholine on some muscarinic receptors in your skeletal muscle that will also increase vasodilation, which is that exception to the rule of the sympathetic nervous system, as you have some of these muscarinic receptors in skeletal muscle blood vessels that you don't have in your periphery or in your skin blood vessels, okay? So that's how we end up using the sympathetic nervous system, which generally, as a whole, proportionally, especially at rest, causes general background vasoconstriction. But during exercise, it causes vasodilation specific to skeletal muscle via these couple means. Okay. We do have sympathetic control to our head and neck. It's identical to the rest of the body, but it also does something specific like dilating the pupil. It innervates the smooth muscle portion of the levator palpebrae superioris muscle. If you remember that little portion of the muscle to help lift the eyelid up, there's a little bit of sympathetic control of that. And we'll talk about a specific syndrome called Horner syndrome when you damage the sympathetic fibers going to that muscle that come down here from your head and neck, that you might have a little bit of a droopy eyelid. To your salivary glands for salivation, and then sweat glands to your face and head. Okay. Sympathetic regulates the viscera via increased heart rate and contractility via stimulation of beta-1 receptors with norepinephrine not binding to those, and then dilation of the bronchial tree via stimulation of beta-2 receptors that have a predominance. It's not like in the heart rate you still have some beta-2s. It's just a greater preponderance of beta-1s. The same thing with the bronchial tree. You have some beta-1s in there, but you have a greater preponderance of beta-2s. But when you start getting into side effects of medication, then you realize, especially for some of these things, when you have somebody with a dry mouth or their heart rate races when they, take certain medications, or they have, problems with bladder control, you'll start to see how you're affecting sympathetic and parasympathetic systems because they're antagonizing, or they're acting as an antagonist or agonist to these different receptors. And some have a prevalence to stimulate certain receptors more than others, but they still will fall on some of the other receptors and cause some unwanted side effects because it's not like these are all or nothing as far as the receptors you have in certain locations. Usually there's a little bit of combination of receptors. So they do their best to try to design medications so they really bind to one type of receptor, but they'll also tend to bind to the other receptor some, or weakly, but still cause some of these unwanted side effects and so forth. And then for sexual function too, the sympathetic is important specifically for ejaculation and for that function. And we'll get into that when we get to the spinal cord, and we'll talk about regulation of sexual function and the complexities of that in the future. Any questions on that sympathetic nervous system at this point? Yeah.
I have one back, 2 slides.
Yep.
For the bottom 2 bullets with the exercise, is one of those, like, is the second one used more with long-term exercise since it's the muscarinic receptors, or are they both used, like, during exercise as well?
Both are used during exercise in general. I don't know that one's more this will cause some longer lasting effects, and so will this. So there's you have the warm-up period. The warm-up period is to get these systems to start to get active and start opening up and dilating blood vessels in but also warming up tissue too, just warming up tissue in general so you don't injure yourself, and warm up tendons and ligaments and so forth. But you're giving time. But then the cool down period, there's some after effect because you still have epinephrine circulating, you still have those acetylcholine working on those muscarinic receptors, which are a little longer acting. So there's that 3 to 5 minute recovery to kind of get things to come back to normal. So, but yeah. Okay, you can take a break. Come back in about 10 after here. Okay, let's just cover parasympathetic nervous system. So this is going to have mostly opposite actions of the sympathetic nervous system. So the cell bodies for the origin of these are in either the brainstem for the cranial nerve nuclei that are coming from the cranial nerves, the cranial portion of this, or in the S2 to S4 region, which also have a little lateral horn. So I made the mistake of saying that there's only a lateral horn in the thoracic spine. There's a little lateral horn in the sacral spinal cord segments for the sacral division of the parasympathetic neurons. Okay. The ganglia in the parasympathetic nervous system are separate and nearer the effector organ than the sympathetic nervous system. It's called the cranial sacral division of the autonomic nervous system. The cranial division of this is coming, they call it the cranial outflow, is the cranial nerve number 3, 7, 9, and 10. But however, 75% of all the parasympathetic nerve fibers are going out via the vagus nerve, cranial nerve number 10. Okay. And then we have the sacral outflow, which is coming out of the sacral region. And the cell bodies are in that lateral horn of the gray matter between S2 and S4. Those are going to the colon, bladder, and genitals. Okay. So this is just showing you from your book the cranial division, which you can see that this cranial nerve number 10, this vagus nerve, you can see how it's going to pretty much all these organs here, and why it's got 75% of the fibers for parasympathetic control. Then here's your S2 to S4 segments that are just going to the bladder, lower colon, and genitals. Okay. What does it do? Its primary function is energy conservation and storage. It also decreases heart rate and contractility, opposes sympathetic control there, causes bronchioconstriction. It increases digestive activity, glycogen synthesis in the liver, and also glandular secretions. Um, Constriction of the pupil, increased convexity of the lens, makes it more curved, increased curvature of the lens, the voiding of your bowel and bladder, and erection of sexual organs. So that's parasympathetic. Pretty basic, huh? Damage to the autonomic nervous system. So let's talk about some clinically what happens when you damage certain regions of the autonomic nervous system and what the result there is. With deinnervation of the autonomic nervous system, there's initially kind of loss of, especially of all of your sympathetic tone. This is most commonly associated with spinal cord injury. Somebody who has a spinal cord injury above the sympathetic outflow from that T1 to L2 region. Okay, so if you have or you damage a large enough portion of the sympathetic outflow. So if you have a damage to the spinal cord, typically above T6, anywhere above T6, causes your sympathetic nervous system to freak out temporarily. Normally you have higher centers via the dorsal longitudinal fasciculus from your hypothalamus, from your limbic system, from your cortex, and from your brainstem centers that help modulate and help control your sympathetic tone. They help to modulate that. But when you initially damage it right after a spinal cord injury, your sympathetic nervous system says, uh-oh, we're no longer talking to our higher centers. Right now, we don't know what to do, so let's just shut down temporarily. So your sympathetic system kind of shuts down when it loses that initial connection with higher centers. And this is why for somebody who after a spinal cord injury, one of the biggest barriers to getting them just to sit up in a chair, to get them down to therapy, is every time you barely lift their head in the bed, they pass out because they have no sympathetic tone. Their blood vessels in their periphery and their skin. Remember, sympathetic nervous system's primarily role is regulation of blood to your organs and to your body, is regulation of blood flow. So what happens is they're just blood pools, and you just barely tilt their head of their bed up or their head, and their just blood pressure bottoms out and they pass out on you. Eventually, though, your body recovers from that. And to achieve kind of near normal basal levels, your sympathetic reflexes, your spinal cord, say, okay, let's turn up our system a little bit after this period of kind of, we call it neuronal shock, where the nervous system's kind of like, it could take anywhere from 2 to 4 weeks or so. But a big role of this is that your adrenal medulla sitting on top of your kidney realizes your sympathetic tone has dropped, and it'll start to secrete more baseline epinephrine and norepinephrine into your bloodstream, and that helps raise your sympathetic tone regardless of what's happening from the spinal cord centers, to help raise that background vascular tone so you can tolerate changes in position. You still can't change. You can't do it as quickly. So even though after time, some of the spinal cord injury, they can sit up, they can do things, but you still can't make transitions in upright position as quickly, as you could if you had a normally functioning, totally intact, sympathetic nervous system from higher center control. If you damage a peripheral nerve, okay, you will get loss of sympathetic efferents, which cause loss of vascular control, temperature regulation, and sweating in that affected area. That loss often leads to what's called trophic changes in the skin. You'll see their skin gets dry because they're no longer secreting enough from their sweat glands, but also the sebaceous glands for the oils and so forth. So they'll get this dry, flaking, kind of red skin because they lose the vasoconstriction. And they just have it gets red because there's vasodilation in the peripheral skin tissues because you don't have the sympathetic tone maintaining some background vasoconstriction in the skin. Okay, you usually have to damage a pretty big peripheral nerve to note. If you have a damage to a little branch of a little peripheral nerve going to a small region of your skin, there's enough overlap of your innervation, autonomic innervation, that you won't notice it. But if you damage like a brachial plexus injury where you have, avulsion of a nerve root and you've got loss of motor, sensory, and autonomic function to a big region of your skin in a limb, you may notice they have some of these things going on. The other thing you'll notice is this occurs with people with like diabetes and so forth. So when you have peripheral neuropathy, when you start damaging most of the nerves that go to your whole lower limb, some of those have they have autonomic nerves in them, right? So and they have sympathetic control, and so you'll see some of these changes, these vascular, sympathetic type changes that are part of peripheral neuropathy, where they get this dry, flaking, redness-looking skin, and it makes that skin is also gets more fragile, more prone to damage, and then because of other, the glucose regulation, then that they have trouble healing and so forth. But part of it's due to lack of good blood flow regulation to that area, and also the lack of the innervation of the glands. If you damage the spinal cord, like I just mentioned, especially if the lesion is above T6, you can have a phenomenon called autonomic dysreflexia. So you damage above T6, a complete spinal cord lesion. Initially, for the first maybe week to 4 weeks or something like that, you have this neuronal shock and loss of vascular tone where you can't hardly sit them up, blood pressure drops, and so forth. But then over the next few weeks, they start to get some more vascular tone. Their adrenal medulla starts to kick in, raise those baseline epinephrine and norepinephrine levels, and their spinal cord reflexes start to kick in again, which is good, but there's also a negative side effect is they can get overactive sometimes. So they tend to work okay when you do position changes and allows them to tolerate those position changes. But if you cause any pain or trauma or stress to their system, like below the level of the lesion, so maybe they have a full bladder, their catheter is full, or they're sitting on something like a wrinkle on their sheet in their bed, they can't feel their bottom, but there's still pain receptors being stimulated that are going to the spinal cord, and your spinal cord recognizes there's pain happening, and there's some communication right at the spinal cord level with the sympathetic nervous system to create that fight or flight response. And so what happens is your sympathetic nervous system says, uh-oh, we've got pain, we need to do something, and it starts generating sympathetic changes. So your blood vessels start to constrict, because that's the primary role of your sympathetic nervous system, is that background vasoconstriction, and it causes an overconstriction of those, and it shoots their blood pressure sky high. And their heart rate will go up too, because the heart rate, if the heart comes out, the sympathetic outflow for the heart is at T6, just a little bit right at T6 or below is where it goes to your heart. So that's why the damage above T6, you now have eliminated your higher centers from talking to your sympathetic nervous system at the point where your heart starts to get control. And so if you have this pain response coming into your spinal cord below, normally what you would do is you go, oh, I've got a little pain there on my skin, I'll just shift my weight. Or that's not a big deal, and your limbic centers and your higher centers tell your sympathetic nervous system, don't freak out. Hey, we can get away from this pain. We can shift our body weight. It's not that big a deal. It's not a fight or flight response thing here. But if you don't have your higher centers to tell your sympathetic nervous system like that, they go haywire and they just do this all or nothing kind of response. Like, uh-oh, panic, hit the panic button, sympathetic tone increase, create heart rate go up, blood pressure go up, and you can have a person with a spinal cord injury stroke out on you because now they can't then modulate. What happens is then the rest of their body above where that system is, where that damage is, has to try to accommodate for all the sympathetic tone going up here, so they vasodilate above. They get really flushed and red because they're trying to like decrease their blood pressure using their system above. Then they do some vasodilation of the ones above, and so they'll get really sweaty, they'll look flushed and red, their beet red face, they'll have a headache. That's an autonomic dysreflexic response. There's autonomic is dysreflexic. There's a problem with the sympathetic reflexes going on there. And they don't have enough of their proportion of their body properly innervated to accommodate or counteract that abnormal response, if that makes sense. And that's an emergency situation. That's usually, you have to figure out what the problem is that patient is experiencing that's leading to that. Usually Most of the time, it's a full bladder or their bowels or their bladder are too full, and there's increased stretch on their bowel or bladder, and they just need to either be catheterized, or there's a blockage, or their catheter bag's full, or they have to, have a suppository and have a bowel movement or something like that, or they're sitting on something, or they're getting a pressure sore, that kind of thing. You have to then alleviate that stress. You got to shift their position. You got to empty their catheter bag for them. Most of the time, the patients over time get to know what elicits that, and a lot of times there's a little bit of a precursor. They can tell when their blood pressure is starting to elevate and their sympathetic system starting to go a little haywire, and they know, oh, it's time for me to go to the bathroom and catheterize, because I can start to tell I'm getting a little dysreflexic. I'm getting a little dysreflexic, and they get more in tune with their body, and they get to be able to regulate that. But if you can't figure it out, you got to tell a nurse. And there's different, so for somebody who's got low sympathetic tone, when they're in that period of neuronal shock and you try to sit them up and they start passing out, you lay them back down a little bit. Somebody with autonomic dysreflexia who's got increased sympathetic tone, increased blood pressure and heart rate, you don't want to lay them back down. You want to keep them upright, because you want to make it harder for the blood to get to their head and have them stroke out. So you don't want to lay them back down. With somebody who's got the low sympathetic tone, their face they'll get white, and they'll still may get diaphoretic, and they still may get some sweaty diaphoretic, and they'll be white and kind of difficulty with, like, even kind of consciousness and so forth. Somebody with autonomic dysreflexia, they're going to be beet red, and they're going to have a pounding headache possibly. They're not going to, and their alertness is going to be fine, because they've got blood pressure that's high. They're not losing consciousness and so forth. So that's autonomic dysreflexia. And you really don't have to worry about it if you come in, the person's got a lesion above T6. If the lesion's below T6, pretty good chance they're not going to have autonomic dysreflexia. Or if it is, it's going to be mild. Damage to the brainstem can cause a myriad of problems. You can have interference with maintaining heart rate. A lot of times their heart rate level shoots way up with brainstem damage, and they just have a high resting heart rate. Respiratory rate can be up or down. Blood pressure, cranial nerves, thoracic and abdominal viscera. When you have patients who have brainstem damage, you can have a whole host of autonomic. You just have to assess the patient. You just, like, if you know there's brainstem damage, they've got a stroke in the brainstem or something like that, you're going to do your systems assessment. You're going to check heart rate, respiratory rate, blood pressure, okay? And look for vascular changes and things. But you're just seeing physiologically where are they at rest and what happens during exercise, and make adjustments accordingly, okay, if you need to. Damage to the cerebrum, especially the hypothalamus, can affect all kinds of things. It can affect your overall homeostasis. It can cause metabolic disorders. Even things like obesity and anorexia can be caused by damage to certain centers in the hypothalamus and can lead to those problems. Somebody has a tumor that's affecting that, or a lesion affecting that in a specific region. Temperature regulation can be affected with the hypothalamic damage. So yeah, if you see on an MRI, they say the patient has some kind of a stroke or damage to the hypothalamus, or tumor in that region, you just are going to be looking for potential effects on autonomic function that can be quite varied depending on where the location of that is in the hypothalamus. Assessing autonomic function, you guys are going to do more of this in general medicine when you get to general medicine. You guys done blood pressure, heart rate yet, and all that? So you've done some of it. But heart rate, blood pressure. For blood pressure and heart rate, supine and standing. So if you're looking for orthostatic hypotension, where your blood pressure maybe changes too much with changes in body position, if you get a 30 millimeter per mercury drop in your systolic, or a 15 millimeter mercury drop in your diastolic, that's typically considered abnormal. Like, you just don't have a good enough sympathetic nervous system to adjust your vascular tone to accommodate that change in position, okay? Or you're dehydrated and don't have enough blood volume, to keep your blood pressure at a reasonable level when you go from a sitting or standing position. So respiratory rate is another good indicator of just what's going on with the sympathetic or parasympathetic nervous system. What's a baseline respiratory rate, and how does the respiratory rate respond to exercise? And then skin inspection. Don't forget, your skin and your glands, your basic, oil and sweat glands, and also the vasculature to your skin will be influenced and give your skin different looks that you'll start to notice that when you start seeing people with a lot of diabetic neuropathies and so forth, that ooh, that's a vascular, or not vascular, an autonomic skin change that is occurring with this chronic dysfunction of especially the sympathetic nervous system. Sweet, that was done a little faster than I thought.